Hi, my name is Osei, and today I hope I can teach you a little bit about clinical examination of the respiratory system. Sorry as well, my laptop's a bit slow, so if it's interrupting, I'll try my best to fix it. Okay, so in general, for all examinations and not just respiratory, there's a general outline which you want to do. So first, obviously, where you want to introduce yourself, tell the patient what you're about to do, and gain their consent for the examination. It's always nice to ask if they're in any pain at all, because during the examination, you're probably going to be moving them around, you're going to be asking them to do some movements, and you want to know beforehand if they're in any pain so you can sort of amend your examination if you take this into account. Then you want to do the sort of general look, feel, and listen for signs, depending on what sort of examination you're doing. So in today's case, we're doing a respiratory examination. So if you want to do a small little general examination, you can learn a lot about a patient by just looking at them from a distance. You can get a rough idea about how unwell they are, and just by looking a little bit about if they're in any pain or any discomfort. Generally, for a respiratory examination, you want them to be exposed from the belly up so you can get a good look at their chest, and you want them to be lying down on the bed at about 45 degrees. So they're not completely flat, but they're a little bit upright. You want to see if they're in a position themselves in a certain way to make it easier for themselves to breathe. They could be using accessory muscles to help with their breathing. So these are all signs of increased work of breathing, meaning they need to use a lot more effort to breathe, whereas normally you just do it passively. You might want to take a little bit look around the bed. Hopefully at this point you've already spoken to the patient, you have a little bit idea of what's going on, but you can also get clues from other areas. Maybe you could see inhalers that will tell you if the patient has asthma or if they have any medication with them themselves, so you can see if they've already tried something and that's not really worked. When talking to the patient, you want to have a little listen to how they're talking to you. So are they able to speak to you without interrupting? Or do they have to stop in the middle of their sentence to take a breath? See if they've collected any sputum or phlegm themselves. And just by looking at that, you can get a little idea about their illness as well. So have they produced quite a lot of sputum? Are there loads of tissues around full of it? What kind of color does it have? Does it have a certain smell? And if you look at the bottom, you can see that different colors could signify different things. With this alone, you can get a lot better idea about how the patient is doing and what's going on with them. Next, usually you can take a little closer look at their hands. So while their arms are outstretched, you can feel for both their arms and their hands, see if they're warm. You want to see if they're warm on both sides. You can do a cap refill, which is just pressing on the nail for about 5 seconds and seeing if the blood returns to their finger within 2 seconds, which is normal. This is all just signs to see if the patient is actually perfused and if their blood is circulating well. You can also check for sort of tar staining, which is a sign of long-term smoking or tobacco use. And obviously, we know with patients, if they've been smoking for a long time, then they're at increased risk of respiratory diseases as a result. If a patient comes to you saying they're feeling quite breathless, they can't exercise as much, and you see this, which is koilonychia, this is a sign of iron deficiency anemia, which can also cause breathlessness in a patient. So while it's not a respiratory thing, it can cause respiratory symptoms. And while also looking at the arms, you can take their pulse rate and their respiratory rate. Usually we say to take the respiratory rate without telling them you're doing so, because they might change the way they're breathing if you tell them that you're looking at how fast they're breathing. You can also look for clubbing, which is shown at the bottom. Normally you see this gap in between the fingers, but with those with clubbing, they don't have this gap. And while looking at the arms, you can ask the patient to outstretch their arms and pretend they're pushing out onto a wall. This to assess for tremor. If you look here, this is a sign called flapping tremor. So this happens when a patient has severe CO2 retention. So this is when they're in severe respiratory failure. And if a patient has this sign, they're usually very confused because their body is no longer getting the oxygen and they're no longer breathing out carbon dioxide like they should. if we just move back to clubbing, there's loads of reasons why a patient might have clubbing, but these are just some of the respiratory causes that could cause clubbing and signs like this. And if you get the patient to put their fingers like this, as I showed previously, then you can see if there's a gap present. There are other causes for clubbing, such as heart causes or gastrointestinal causes, but for the sake of today, I only just wrote down the respiratory causes. And this is usually due to long-standing hypoxia, reduced oxygen in the blood. So next, you want to take a little look at their neck, and you can assess for JV, take a little look at their face. Sorry, I skipped a bit. So you might want to look for polycythemia, which is their face might look a little bit redder than usual, and this is due to long-standing reduced oxygen in the blood, so they produce more blood to sort of make up for the reduced oxygen. Emphysema can cause patients to have this pursed lip breathing, which is when they breathe out, they put their lips outwards to sort of try and keep their chest from closing in faster than it should. You can also look for signs of central cyanosis, so maybe their lips are quite blue. If you look underneath their tongue, it might also look blue, which means they're not getting enough oxygen, and if you see a patient with that, you obviously want to quickly give them some oxygen. Another thing that you might forget to look at is the eyes. So if you look at the eyes and you see their eyelids drooping, their eye pupil is constricted, and they don't have much sweating, this is a sign of, this is called Horner syndrome. And Horner syndrome can be caused by lung cancers, which are typically at the apex of the lung. So this is also something else you could look for. So while looking at the neck, you can assess for JVP, which is the increased jugular venous pulse. So this could be a sign of right-sided heart failure, which could be caused by a chronic lung disease, or it could be caused by a pulmonary embolism. You also want to palpate for the trachea, as you can see in this picture over here. This is quite uncomfortable for the patient, so tell them before you do that. And you want the trachea to be central, but if it's not, that could be a sign of something more sinister. So here I'm just showing you a table about what trachea deviation could mean. From examination alone, you probably won't know what side a lesion or abnormality is, but hopefully with history and imaging, you can work out what it is. So by taking a closer look at the chest as it is, you can learn a little bit more about the history of a patient. So scars can show from previous surgeries, or if they have any chest deformities, this could make it harder for them to breathe because their chest wall isn't made the way yours or mine is. So you also want to assess for chest expansion. This is a sort of way to test to see if the breathing is equal on both sides. So you place the hands around the chest. The best way to do is ask them to take a deep breath out, and while they're taking a deep breath out, you grab onto their chest, and then ask them to take a deep breath in with your thumbs above. And when they breathe in, see how far away your thumbs are traveling away from each other. Your thumbs should be moving the same distance apart from each other, but if they're not, then that's a sign of unequal chest expansion. So next is percussion, and this is a skill you got to get a little bit used to. So using the middle fingers, you place one of your fingers on the chest wall and then use the other finger to sort of hit your middle finger. By doing this, you should make a little, like a drum sound, and you want to do this in both places, both sides of the lung, to see if the sound made on one side of the chest is the same on the other side. And you want to do this in all intercostal spaces, and you can do it directly onto the clavicles rather than using your other middle finger. So compare both left and right and see what sound you get. So a normal sound would be resonant, which is what you expect, but sometimes you might hear something where it's hyperresonant, which could be a sign of pneumothorax or emphysema. I know you guys are going to get your pneumothorax lecture next week, so you'll learn a little bit more about this. But it's the sort of, if you think about percussion sounds, it's sort of like physics. If you have a container which is empty and you hit it, it will sound hyperresonant. So air in the lung will sound hyperresonant. Whereas if there's something in the container, such as pneumonia, then it will sound a lot more dull. So same with the lung. If you hit the lung and it sounds empty, then you could think there's air in the lung there shouldn't be. And if it sounds a bit dull, then you know that there's something else going on as well. So same with percussion, you want to auscultate. So using a stethoscope, you want to listen into the lungs. Same areas you percuss, you want to listen in. And usually we want to take a little bit of time when doing this so you can fully appreciate what you're listening to. If you ask the patient to open their mouth while you do this, it reduces the noise going in through the nose. And don't ask them to breathe too fast because then they might get a little bit dizzy. So just ask them to breathe normally, listen in both sides of the chest and compare. There are quite a few abnormal breathing sounds that you could hear while listening into the chest. So bronchial breathing is when something in your upper airways is causing the airflow to be obstructed, and so it will sound a lot louder than you'd expect it to hear. What you usually hear is vesicular breathing, which is quite soft and it's not very harsh. And inspiration should be longer than expiration. On the opposite side of that, you could have a silent chest. So if you're not hearing breathing at all, then that's obviously a very abnormal sign. You don't want to hear diminished breathing sounds. It could be a sign that your patient's gone overly tired from breathing too much. And so now they aren't trying to breathe at all. And then obviously this is a medical emergency. Stridor could mean that there's something in the airways that's stuck. Maybe the patient's breathed something in, or if there's a malignancy which is causing blockage somewhere. Wheeze is quite common in asthma. And pleural rub and cracklings can be a sign of a bunch of different things, but it's usually to do with pneumonias and things like that. So tactile vocal phrenitis is another way that you could see if there's increased things in the lungs that shouldn't be there. So things like pneumonia and stuff like that. It's not really used so much clinically from what I've seen, but it's still a skill that you can learn. So by placing the side of your hand on the patient's chest and asking them to speak, you should be able to feel vibration. If you do it on yourself, that should be the normal amount of vibration. But if you're feeling increased vibration, that could be a sign of pneumonia. Same again with physics. If there's a lot more solid, then the sound waves travel a lot easier, and so you'll feel increased vibration. But if you don't feel that vibration, something's blocking the sound from getting to the front of your chest. So that could be pleural effusion. There could be water in the lung, which is preventing the vibrations from getting through, or there could be air, like pneumothorax, preventing the vibrations from getting all the way through. So you've done all this at the front. You want to repeat this all on the back. So doing it again, assessing for chest expansion, passing all the areas and auscultating. I find that when you auscultate on the back, it's a lot easier to hear for lung sounds. So if you miss something from the front, you're more likely to hear it at the back. So it's really important to do both front and back. While you're on the back, you can feel and palpate for the lymph nodes. You do this slowly and systemically so you don't forget certain lymph nodes. If they're inflamed, it could be a sign of infection, or if it's been there for a while, it could be also another sign of cancer. So while you're looking at the patient's back, you can do a cervical and a lymph node examination. So additional investigations that you can do for respiratory is a peak flow. So this is a little tube you can ask the patient to blow into to see how hard they are breathing, or if they have a quite weak breath. This is usually done for people with asthma. You can collect the sputum as well. You can, not just by looking at the color, you can send it off to a microscopy so you can see if there's any bacteria in it or any blood. You can do normal bloods or an ABG, so an arterial blood gas, and that's usually done to assess for respiratory failures. And obviously you can do a chest x-ray to see if there's anything that there is to be seen in the lung. So I've added some resources as well at the end to see that you guys can look at in your own time. So there's a full respiratory examination so you can see it done from start to finish. And a lot of the lung sounds are hard to explain, but if you hear them over and over again, then you can start to recognize them. So if you use this site as well, it's quite a good useful site for you to use to practice hearing lung sounds and recognizing them in your own free time. So yeah, thank you very much. Sorry, it was quite fast. I didn't realize time-wise.